All right, today we're jumping right into a high-yield review of beta thalassemia trait. Now, this is a topic that comes up all the time, whether you're prepping for specialty exams or you're in your daily practice. So this explainer is definitely for you.
And before we get started, I want to give a huge credit to the source for this session. It's all based on the fantastic work of Dr. Mohammed Al-Nagi Mohammed. We're just distilling these critical points for a quick review. So here's our game plan. We're going to start broad with a quick intro to the thalassemias. Then we'll zero in on the trait itself. After that, we'll cover the clinical and lab features you'll see, nail down the key diagnostic marker, and finally, wrap up with why all of this is so important in practice.
Okay, let's kick things off with Section 1, the thalassemias. To really get a handle on the trait, we first have to understand the bigger family of disorders it's a part of. So, what's the deal with the thalassemias? Well, at their core, they're a fascinating group of genetic disorders. The key issue isn't about the quality of the globin chains in your hemoglobin, it's about the quantity. There's just not enough of either the alpha or the beta chains being made. Think of it like a factory with a major production slowdown.
All right, now for our main event. Let's define the trait, which you'll also hear called beta thalassemia minor.
So, beta thalassemia trait is essentially the carrier state. What does that mean for the patient? It usually shows up as a mild hypochromic microcytic anemia. Hypochromic just means the red cells look a bit pale, and microcytic means they're smaller than usual. And it all goes back to that production slowdown of beta globin chains we just talked about.
And here's where the genetics get really interesting. It's an autosomal recessive condition. Now, this is absolutely crucial. It means to get the really severe form of the disease, you need to inherit a faulty gene from both parents. If you just have the trait, it means you're a carrier with one copy. And trust me, we're going to circle back to why that is so important.
So we know what it is on a genetic level, but what does it actually look like when a patient's lab results hit your desk? That brings us to Section 3, clinical and lab features.
Well, the first thing to know is that people with the trait are almost always completely asymptomatic. They feel fine. You're not going to find this because someone comes in with complaints. It's usually an accidental discovery on a routine blood test, or maybe it gets flagged during family or antenatal screening.
Okay, now this is the clinical pearl, the big one to remember for your exams. There's a totally disproportionate relationship between the anemia and the microcytosis. The anemia itself is super mild, maybe barely there. But the red cells, they are markedly small. The MCV is way lower than you'd ever expect for such a tiny drop in hemoglobin. That mismatch should set off alarm bells in your head and make you think, could this be thalassemia trait?
So that brings us to Section 4. You've got your suspicion based on that blood count, so how do you actually lock in the diagnosis?
So, what's the next step? What's the one test you need to order to clinch it and be absolutely certain?
The answer is hemoglobin electrophoresis. This test basically separates out all the different types of hemoglobin floating around in the blood, and that gives you your definitive answer. And here it is, the number, the one you have to commit to memory. A raised hemoglobin A2 or HbA2 level of over 3.5% is diagnostic. If you see that in a patient with that unexplained microcytosis we talked about, you've got your diagnosis. It's the classic textbook finding. And just to add another piece to the puzzle, you might also notice that the hemoglobin F, the fetal hemoglobin, is either normal or maybe just a little bit elevated. It's just another finding that backs up your diagnosis. So, we've found it. We've confirmed it. But so what? Why does it even matter? This brings us to our final and, honestly, our most important section, the significance in practice. Here's the thing. For the patient themselves, the diagnosis doesn't really change much. They're asymptomatic, they feel fine. The real primary clinical importance is all about genetic counseling. It's about planning for the next generation.
This is where the rubber meets the road. What happens, what is the risk, when two carriers, two people who both have beta thalassemia trait, plan to have a child together?
And here's that classic autosomal recessive pattern in action. For every single pregnancy, if both parents are carriers, there is a 25%, a 1 in 4, chance that their child will have beta thalassemia major, a very severe transfusion-dependent anemia. There's a 50% chance their child will be a carrier, just like them, and a 25% chance their child will be completely unaffected. This is exactly why we screen and why we counsel.
Okay, let's do a super quick recap. The absolute must-know points. 1. Beta thalassemia trait is an asymptomatic, mild microcytic anemia. 2. Your key clue is that disproportionate microcytosis, tiny cells, barely any anemia. 3. You diagnose it with an HbA2 level over 3.5%. And 4. Its biggest role in the clinic is for genetic counseling.
And I'll leave you with a final question to chew on. Thinking about this as a genetic condition that's more common in certain parts of the world, in which patient populations is screening for this trait most critical from a public health perspective? Thanks for joining this explainer.